Greetings, investors. Welcome to Investor's Edge. My name is Gene Melamud. I'm here with my esteemed colleague,
Hunter Burnett.
We are fortunate to have a guest with us today who will be helping us navigate through some of the Medicare questions. I've known this man for 25 years or longer. His name is Tim Ripp. Hi, Tim.
Hi everybody. Hi, Gene. Tim Ripp, Associate Clifton Park, National Sales Manager Director. I've traveled the country, have all the cards to show it, but my career has been involved in basically specializing in estate planning and Medicare planning and long-term care planning, working with thousands of advisors, helping them understand the intricacies and bringing that message and information to their clients. We provide in-house services to advisors for their clients to contact us. We will help them walk through the intricacies of Medicare planning or on behalf of the advisor long-term care planning.
So can you please clarify to our viewers what's the relationship of Associates of Clifton Park and Raymond James so that everybody is clear?
Yes, we are an independent consulting firm in the Medicare long-term care and life insurance arena. Raymond James brought us into their family about 25 years ago to help them with their long-term care planning and Medicare planning. And we've been affiliated with Raymond James as what's called a preferred partner for the last 25 years.
And so, Tim, can you please kick us off and tell us about the ABCs of Medicare? There's the whole alphabet soup. Can you please start off?
Sure. I mean, one thing is, if anything, Medicare is really creative in labeling things, A, B, C, D. But Medicare is really two main parts, Part A and Part B. Part A is your hospital insurance, provides coverage for in-hospital care, recovery care in a skilled nursing facility, hospice care, and some limited home care, okay, for recovery. Part A is typically free. You don't pay for Part A because you've paid for Part A during your work history. That's the FICA deduction taken out of your paycheck every month or 2 weeks or week. As long as you've worked 10 years and paid in or 40 quarters, Part A is free, okay? Part B is your medical insurance part. This covers your medically necessary and preventative services typically provided by physicians out of the hospital in a physician's office and so forth. You do have out-of-pocket expenses. Part B is usually an 80-20, where you have a Part B deductible, which in 2024 was $240. It'll probably go up $10 or $12 for 2025. The numbers are released in about 4 weeks. And then you have an 80-20 copay. You can buy Medicare supplement insurance to cover that 20%. And specialty hospitals and specialty doctors are allowed to charge an excess of 15%, which can also be covered. And then there's Part D. Part D is your prescription drug program. Some Medicare under, we'll talk about it in a minute, but Part D will cover your prescription drugs. With recent legislation this year, starting in 2025, they're going to limit your Part D out-of-pocket exposure to $2,000 a calendar year, down from about $3,800. And one of the nice things is that currently seniors under Medicare only pay $35 for insulin diabetes type of care. And then there's Medicare Part C. Medicare Part C is what we call private Medicare. Some people have said we shouldn't even label it private Medicare or have the name Medicare attached to it. It's really private health insurance. What Medicare Part C is where the federal government contracts with private HMOs typically to provide healthcare services. There are some limitations occasionally. You typically, if you're in an HMO, you have to stay within the network for in-network care. If you go out of network, you could have a lot of financial exposure. Care is somewhat monitored in terms of where you have to get pre-approval for certain types of care where you wouldn't with original Medicare. And many times they utilize what we call step therapy, where they will not provide you with the most efficient and newest type of care model because it's expensive, and they'll try out with an older, lower cost model to see if you do well with that. And so Medicare Part C is growing in popularity. Currently, right now, about 50% of the Medicare population, a little under 50%, is enrolled in Medicare Part C. The remainder of the 51% or 50% plus is still in original Medicare.
Wow. So it's an overwhelming amount of information. So I'm hoping that you can clarify a couple of things for our viewers. First of all, for our viewers, how do they know what is the right plan for them? And when you answer that question, if you could please explain the difference between Medicare and Medicare Advantage as well, and also clarify, you mentioned that there is some benefit, limited benefit for long-term care. And since long-term care as we get older becomes one of the major expenses of the estate, folks should still plan for long-term care as separate coverage, right? Because there's not enough coverage through Medicare, correct?
Oh yeah. I mean, one of the, if you were, you can request from CMS Centers for Medicare Services, you can request the yearly guide to Medicare. And like on page 12, they list things that Medicare does not cover. And bullet point number 3 or 4 is Medicare does not cover long-term care. Medicare, yes, there has been some recent legislation with Medicare Advantage plans saying that we provide home care, we provide this, we provide that. It's on a plan-by-plan basis. One thing to remember is benefits on a Medicare Advantage plan change annually at renewal. So you can have the benefit one year, not the next year. And what we have found that those benefits are very limiting. When they say we provide home health care, what they're providing is typically 1 or 2 days a month of assistance, which is really not home health care, because if you need home health care, you need it the whole month. And so there are very limited benefits. But Medicare specifically says this is not long-term care, because when we define Medicare, we define it as acute care. You get sick, there's a diagnosis, there's a course of treatment, be it hospitalization, surgery, physical therapy, drugs, whatever, to get you better. And once they get you better, and you plateaued in your recovery, they discharge you from care, quote unquote. If you still need help at that time, let's say you had a stroke, and the first 72 hours after the stroke are the most critical hours of recovery, that's when about 90 to 95% of the recovery occurs. After 3 or 4 days in the hospital, they go to discharge you. They may discharge you to rehab under Medicare for a few weeks, but once you're discharged from there, and you still have residual effects from the stroke, that when they say we discharge you because there's nothing more we can do to improve your situation, you automatically go into a long-term care situation where then you're faced with out-of-pocket costs for assistance at home, for maybe addressing lifts in your house or ramps or things like that.
Right.
That's where long-term care insurance can step in right away and help pay for some of that. But there's a very fine line where your Medicare coverage stops because it's for acute care, and long-term care starts because it's considered chronic care. Now philosophically, the difference between what I call original Medicare, just a little history. Medicare was started in 1965. The thought process came out of John Kennedy. After his assassination, Lyndon Johnson carried the torch and was able to enact what we call the Great Society Act, Medicare and Medicaid and so forth. But prior to 1965, many people who were old, who had retired in this country, didn't have access to health insurance.
Wow.
Because when they retired, they lost their company's health insurance, unless it was a big company and they carried them on. But most companies discontinued you from their health insurance, and it's very hard to get it. So many people worked their whole lives, had some financial stability, went into retirement, had no access to health care, and had to pay for it out of pocket, and it destroyed a lot of families financially. So Medicare was created on the social concept that if you contribute while you're working, we will take care of you theoretically from age 65 to the end of your life. Okay, and it was a very nice program. It evolved and evolved. It got a little expensive, so they started putting in some deductibles and co-payments. But in the 80s, the private insurance industry kind of awoken to the fact that a large segment of the population demographically was moving toward that over 65 marketplace in the next 25 years, which has happened.
Tim, let me ask you a quick question off that, actually. For those folks hitting over age 65 that are the private insurance is going after, are they automatically enrolled in Medicare nowadays? Or
no, you're not automatically enrolled in Medicare. You have to physically call Medicare or go online and register for Medicare. Unless you're already on Medicare disability, then you're automatically enrolled in Medicare.
Okay.
You have end-stage renal failure or something like that at 58 and you've been on Medicare, then you're automatically enrolled. But if you're just working and you turn 65, typically you're going to contact the Medicare, it's through Social Security, contact Social Security, register for Medicare Part A because it's free. It joins with your health insurance at work, okay? And then when you officially retire, then you contact them again and enroll in Medicare Part B. But it's not automatic. You have to contact Social Security to enroll.
It's great to know. Awesome.
So just getting back a little bit to the differences between original Medicare and Medicare Advantage. So in the 80s, big health insurance companies saw the profitability of being able to play in this arena of older healthcare and Medicare, and started pushing talking heads in Washington to start bad-mouthing Medicare, saying, oh, Medicare is costing us too much money, we need to privatize it, we need to do this, we need to do that, pushing a lot of money toward them probably. And again, I'm just assuming as a fly in the wall. And next thing you know, they're pushing this thing called Medicare Advantage or Part C. It failed twice. What happened twice is they launched it, heavily subsidized it, and when they pulled the subsidies back, the carriers said it was too expensive and dropped out of the market. The third foray is this one. It's been around quite a while. The government has kept the subsidies up, even though there's been malarkey to the tunes of billions of dollars of overbilling. But the federal government is not going after it, even though it's been proven that these big health HMOs have overbilled. But it is a money thing. And so one of the things is you've taken the original fee-for-service, where the concept with original Medicare is you could go to any doctor, any hospital, anywhere in the U.S., walk in and get health care. Okay, so you go to the Mayo Clinic, go to Sloan Kettering, Cleveland Clinic, any of those places except Medicare, all right? And there was no network. You could go to any doctor, seek out, the best services. And those doctors were paid a fee, and if you had a Medicare supplement, you were typically not out of pocket with a good Medicare supplement, all right? And if the doctor said, Tim, there's a new treatment course for your type of disease, it's innovative, he could just start me on that treatment course and Medicare would pay for it. On the flip side, Medicare Advantage has a lot of gatekeepers. One of the things that attracts people to Medicare Advantage is that every big Medicare Advantage company has 10 to 14 plans, all at different levels of premium. The most popular plan, believe it or not, is the $0 premium plan. About 68% of people enrolled in Medicare Advantage plans are in a $0 premium plan, meaning they don't pay anything.
I can see why it's the most popular.
No such thing as a free lunch. If it looks too good to be true, it's not. And what people have found with $0 Medicare Advantage plans is that they have a very limited network of doctors, many times no specialists, and a limited network to hospital access. Typically not the university or the big teaching hospitals where the most innovative care is provided, more of the smaller hospitals. And what you find with these low cost plans is the less you pay up front, the more you pay when you get sick in terms of deductibles, co-payments, and co-insurance. Medicare Advantage plans can have up to 40% co-insurance, so it can get very expensive very fast.
Wow.
Wow.
And the problem is people don't realize this until they get sick. Most people at 65 are what? They're relatively healthy. They have some nickel and dime things, maybe some blood pressure, maybe some gout, this or that, but they're relatively healthy. But when they're 78 or 80, when they get sick, then all of a sudden now they realize their care is being limited, or their care is being marshaled or being spaced out because the HMO doesn't want to spend that kind of money because it bites into their profit line. I mean, if I'm 65 and healthy and the government's giving me $2,400 a month to take care of me, and all I do is get a physical once a year for, let's say, $1,000, I mean, that HMO has made some good money. But if I'm 84 and I'm in and out of the hospital and I have a lot of chronic diseases, then all of a sudden that $24,000 isn't scratching the surface on what they need to pay out, and so they become somewhat slow in providing care. One of the things is, with original Medicare, your medical relationship is between you and your doctor. You and your doctor are making those decisions. If you're in Medical Advantage, if you're in Medicare Advantage Part C, it's a three-way relationship. It's you, your doctor, and the home office plan administrator. So anytime your doctor wants to move forward on a plan of care, he or she has to contact the plan administrator, and they have to review it and then give the doctor permission. If you go ahead and seek that care without the plan administrator's permission, it's not covered. So you get sick, you go to your doctor, he says, Tim, we need to start you, but I have to wait till I get permission. One of the things is that HMO knows if they get 100 cases like this in a month, like your condition, and they know if they wait 40 days to make approval, 15% of those cases will disappear, the people have passed, then that's what they do, they delay care. The other thing they do is they do step therapy. They typically don't utilize the most newest technology or care models because it's expensive. They typically use the older models, which are less efficient because it costs them less money. And if you don't show improvement, then they'll step you up to the next level. Okay? And it's really a managed care situation. So, and at the end of the day, original Medicare is administered and run by the federal government, which is really a non-for-profit. Okay? And at the highest level, what's the highest administrator paid at the federal government? Maybe $500,000, maybe $400,000, director of CMS or something. But most people are just working there as, in administration, probably making $100,000, $200,000. You can Google this, Google compensation at Kaiser. I did it because of curiosity. There are over, I think, 60 people or 70 people at Kaiser who make over $1 million in excess in salary. And there are 5 or 6 people who make over $15 million a year in salary at Kaiser Permanente.
Wow.
Now, Kaiser Permanente is a non-for-profit health insurance company.
Wow.
They are really just a paper-pushing organization. They don't train and have run medical schools and they hire doctors, they run healthcare plans, but they're really, all they do is get claims, adjudicate claims, and pay claims. And you have someone making $22 million as a CEO of Kaiser Permanente as a non-for-profit. You have several people making between 15 and 20 million. It's just, when you think about it, there's a tremendous amount of profit in these HMOs, which we don't see reflected in Medicare. My philosophy is, do you want to be in a health insurance program where providing health care directly is their modus of operandi with no concern for profit, or do you want to be in a health care program where at the end of the day, decisions are made not on what's best for you healthcare wise, but really what's best for the bottom line for that HMO.
I think these issues are so complex, and I think what's important to our viewers is to know that when our customer calls and says that they're wrestling with Medicare questions and are asking for our assistance, then we can organize a meeting with a representative of Associates of Clifton Park that can review your specific situation and help you navigate through this very complex map of different plans, different formularies, different benefits, what's right for you. So I think it's important for our viewers to know we don't expect you to have all the answers after this presentation, but I think hopefully you recognize how complex it is and that we have the resource to help you in the very custom way. So,
and it's even more complex. Two things I didn't mention. Original Medicare does no advertising on the radio or TV. You never see an ad from Medicare about Medicare planning and supplements. But you do see tons of advertisements from who? Joe Namath, William Shatner, Jimmy J. Walker, promoting Medicare Advantage. And the other little secret is, you have these Medicare specialty shops in town. We specialize in Medicare planning. I bet you 90% of their sales are to Medicare Advantage plans, not original Medicare with the Medicare supplement. Why? Because I'm licensed for both. You make about triple the commission annually marketing Medicare Advantage plans versus a Medicare supplement. So there's a financial incentive for all these quote consultants to push what? To push Medicare Advantage plans. And that's what really kind of frosts my feathers, is because the industry is kind of rigged to force, to get people into Medicare Advantage plans.
Great information.
And here's the other thing, is as a salesman selling Medicare Advantage plans at ABC HMO, I make the same commission if I put you in a $0 plan as if I put you in a $200 a month plan. I make the same commission.
Wow.
So what do you think most of those salesmen are pushing?
Naturally. I think this information is so important for viewers. Thank goodness for a review, a replay button, because we've given you so much information today. You can listen to it and listen to it again. And at the end of the day, if you have questions that are specific to you and your needs, give us a call. Cheers. Happy investing.
Thank you, and thank you, Tim.
Thanks, Tim.
Thanks, everybody.